So this goes back to the central question for oncology in the 21st century in some ways, which is the difference between efficacy and effectiveness, right? So there's efficacy for IL-2, no doubt about it, right? If you're one of the 5 to 10% of people who get high-dose IL-2,
it's really good for you.
You're really happy you got it, and you know, one of my colleagues that you know well was on a vacation and was looking for a tennis partner, and it turns out that the person he ended up being paired with was one of his former patients who he had cured 30 years previously with high-dose IL-2. I mean, that's
the ultimate just reward. The
exactly.
Partner on vacation.
Yeah. But you know, that kind of fabulous outcome is what we seek. The problem is that even though IL-2 works incredibly well, it has not really gained enormous traction in the community, because while the few people who do really well, you can't even move the median survival because the proportion of people who benefit is so low. So do you think if you just to get a high enough proportion of really good benefiters, even if it's only 20% or 25%, would that be enough to drive change and to drive wider use?
I think theoretically. I mean, I think the challenge, of course, is, look, 10 to 15% of patients with metastatic kidney cancer don't need initial therapy. Their natural history is such that you can watch them.
Right.
Not a lot of that happens either, because you know, we're in a treating environment. You get treated. I mean, I think the reality is, if there is this sort of the movement of being able to address the kind of clinical trials that we need from a societal perspective, from a payer perspective, we have the potential to show these kinds of endpoints. But we're, as we're all aware, we're in this transition period where it's still about how we do business, and you know, we're still somewhat dependent upon getting people on trials. And in kidney cancer, like a lot of other mature diseases for which there are multiple therapies, we're sort of forced into the second and third line settings where the ability to really show the kind of benefit that we want is more challenging.
I would say that ASCO 2014 is one where social media and patient outreach has come to to us with the ability to now convince patients to take these therapies as first line before getting standard therapy. And that might be the greatest benefit for us to now not do this in failure, but in the first line, to get more patients in and to be able to not have those poor performance status, those those heavily pretreated patients, and show.
Of course, you're
benefits.
preaching to the choir, so
Right.
you know, we all kind of like that story.
So how long do you think these people need to be treated with these drugs? If they're fortunate enough to have the great response in kidney cancer or bladder cancer or melanoma,
and
what's the proper duration of therapy for a PD-L1 axis targeter?
The answer obviously will evolve, but one of the things that I think will inform us is that we already seen, at least in early numbers, retreatment and re-response. So when you start to begin to see that, you begin to wonder whether or not there is a set point in terms of therapy that will be arbitrary. And then as we inform ourselves about retreatment and re-response, that whether it's maintenance or whether it's reinduction, or, I mean, we have a lot of stuff to learn. And I don't know that we're talking about treatment parameters of prolonged therapy. I suspect over the course of 4 to 6 months, you will be able to identify most of the responders, and then some of that may just become a pharmacoeconomic decision, that we empirically say, we see these kind of responses based on this therapy, and then we're going to explore retreatment.
Well, you know, one of the things that gives me hope that we won't have to use these treatments forever is the example of high-dose IL-2, where a single, incredibly toxic but short-lived therapy leads to incredibly durable responses. Those people who have responses, they don't relapse.
And across all the disease spectrums, we've seen patients receiving 2, 3, 4 doses of both these compounds who have durable, prolonged responses.
Absolutely, and the idea of having a response for an extended period of time and then upon progression being retreated and having a response is not just a checkpoint inhibitor thing. It is oncolytics have shown that, definitely. We have seen that in multiple different occasions.
Well, even treatment with trastuzumab on occasion has remarkable effects that we'd like to think have something to do with its signaling properties, but it should be remembered it's an immunotherapy as well. It makes you wonder.
Right.
It does make you wonder.
One of the other things is that with these PD-1, PD-L1 targets, the responses are more rapid. You're seeing that there's truly the kinetics of response are different from anti-CTLA-4, where it took time, where there were late responders, and 80 to 90% of the responders respond by the first imaging. So,
Are there any other clinical trials that have you particularly excited in the genitourinary space when it comes to immunotherapy that you want to discuss?
Well, I mean, I think that, as we've sort of mentioned, the PD-L1 urothelial trials are rapidly opening around the country. PD-1 trials will be soon also in multiple settings, the neoadjuvant setting, patients who are platinum ineligible. So I think that one of the things we need our community colleagues to help us with is, since most of these patients are older, they tend not to want to wind them way into referral centers, we've really got to encourage the movement of these patients into these trials rapidly so we can define the utility of these therapies.
Okay, thank you very much. That was great. So let's turn our